presenting author, Dr. Akash Jain. Here, yeah. So his paper is on evaluating contact of IOL with PC with respect to haptic orientation and CTR implantation using IOCT. Over to you.
Good morning, everyone. My name is Dr. Akash Jain, and this is the topic of my presentation today. I have no financial interest. So, toric IOLs have changed the way we handle our pre-cataract astigmatism, but there's only one problem. They tend to rotate a bit. Maximum rotation that has been noted is during the first hour post-surgery. So, with that kept in mind, we thought of a research question: if we can reduce this early IOL rotation. So this is our intraoperative OCT scan showing the lens. The anterior posterior surface of the lens are the first two lines, and the bottom line is the posterior capsule. Our idea was that if we reduce this gap, if the contact between the lens and the capsule is better, that would in turn lead to a better IOL stability in the eye. So this is what we try to achieve from that. Okay, so our first experiment was to compare whether orienting the haptic of the IOL in a horizontal or a vertical orientation would improve this contact. So with that aim, we proceeded with a study, conducting this study in a sample size of 100. We chose non-complicated cataracts with axial length white to white in normal range, and these were patients opting for a toric IOL. After a preoperative evaluation during surgery, the lens was first oriented horizontally, meaning the haptic was oriented horizontally. A intraop OCT image was taken. After that, in the same eye, at the same IOP, the lens was rotated vertically, and an intraop image was captured again for comparison. So this is a surgical video where I'm showing that after the lens insertion, now the lens is oriented horizontally. The scan to your right is the intraoperative OCT image, and we took a screenshot of the same. Now we proceeded with rotating the lens vertically. And the second image was captured for comparison. So if you compare these two scans, you would notice that I want you to take a look at the scan. The vertical, when the haptics are oriented vertically, the contact is much better as compared to a horizontal orientation of the lens. So that's exactly what we found in our results, where a difference of 20 pixel density is the difference what we had. So that's how we analyzed these two scan images in terms of pixel density. So we had a 20 pixel density improvement with a vertical orientation as compared to a horizontal orientation. We proceeded to the experiment 2, where a CTR, a capsular tension ring, was implanted in these eyes. Sample size was 100. There was a random selection of the CTR size. Again, non-complicated cataract patients with normal biometry values. After preoperative evaluation, we implanted the lens first. We took a scan. We proceeded with a CTR implantation, and we took a scan again. So this is a video showing the same. The lens has been implanted first. After that, the CTR is being implanted here. Yeah, so I just skip the CTR implantation part, and it is very important to ensure that the lens, the IOL, does not get entangled with the CTR. So that adjustment is being made, and then we took the second scan. So comparing these two scans, you would notice that after a CTR implantation, the contact is much better as compared to a pre-CTR implantation, as we see in this scan on when we compare the two. So what CTR does, it stretches the back to increase the contact between the posterior capsule and the IOL, and that's exactly what we found in our results, where CTR of a higher size, say 13, gave a higher contact. The difference was around 50 pixel density here as compared to 11, but there was an improvement with all three sizes. So this is the first study to study CTR and IOL orientation effect in the same eye. A real-time intraoperative OCT scan was done, and these surgeries were conducted at physiological IOP of 20 microns. I also want to draw your attention to that irrigation line. It's the irrigation cannula from eye, which is kept in the eye at IOP of 20 to ensure that the IOP is well maintained during surgery. So how does this study guide us further? So one, we should exercise more caution if we notice any sudden deepening of anterior chamber. While conducting this study, we noticed that sudden deepening these patients are more prone to IOL rotation in the post-op 1 hour period. Further toric IOL stability studies need to be done, but if there is a deepening of anterior chamber noticed in any cases, those patients should be excluded from the study as they can skew your data. So companies can also design toric IOLs which can be positioned vertically for a better IOL contact and in turn leading to a better rotational stability. And try using CTR in toric patients to prevent early rotation. What we noticed was vertical orientation was better as compared to the horizontal orientation, and CTR does improve IOL contact with the posterior capsule. Thank you.
Very innovative study, Dr. Akash. Could you tell me what the size of the CTR you used? 10,
So
12 or 11, 13?
Yeah, the size were 11, 12 and 13. And in this particular study, it was a random choice. But what we can also do in our practice is use the white to white as a consideration. What we routinely follow is that white to white of 10.5 would be eligible for a CTR size 11. Size of 11.5 would be eligible for up to 11.5 would be eligible for a CTR size of 12. Up to 12.5 would be eligible for a CTR size of 13.
You can do the same with an axial length also. Less than 24, 24
Yes.
to 28 and more than 28.
Exactly, correct. Yeah. So
So
these
but
are the
if you-
parameters what we routinely follow during our practice.
Yeah, but you could have done a subgroup analysis also. What CTR size you used and what was the distance between the IOL and the capsule. That can also be analyzed.
What was the
Yes.
sample size?
100 in both arms, ma'am. 100 each, 100 eyes each.
Okay. So did you mention in the methodology that all the cases had a temporal clear corneal phaco?
Yes, ma'am. It was.
Yeah, because the
all-
orientation again, horizontal,
No,
vertical
I
will
completely
change.
understand. Yes, but all cases were. So this was a single surgeon single center study with a temporal topical phacoemulsification at physiological IOP of 20 maintained on the machine.
Quite a different study. Thank you.
Thank you.
Any difference in patients who were high myopes as well?
No, ma'am. We excluded high myopes. We wanted to conduct this study in patients with normal biometry. So we restricted ourselves to a normal axial length, a normal white to white, and a normal IOL power.
Very innovative, but I have a few questions. Number
sir.
one is, you know that if you keep the IOL in a vertical position, you get more of a negative photopsia. So that is one issue. And the other issue is you are measuring the distance between the posterior capsule and the posterior part of the lens. So at what step of the surgery did you do that? And what is the position or status of the irrigation fluid going on?
Correct.
And did you remove all the viscoelastic or not?
Yes. So the lens implantation was a hydro implantation of the lens. There was no viscoelastic use. Second, the irrigation cannula was kept inside continuously during the entire procedure. Third, after ensuring a perfect positioning of the lens, ensuring there's no tilt, the lens is well centered, is only when we opted for the screenshot of the IOCT image.
With
Even
the irrigation on?
With the irrigation on, yes, sir. So that was the whole point of the study, that we actually, in literature, there are many studies which do not consider IOP as one of their criteria. But if you want to compare lens orientation, especially with the posterior capsule, the IOP has to be a set factor. It can't be a confounding factor to the study. Is why irrigation was kept on at a constant irrigation of 20 so that it's more physiological. That was the whole idea of that study, sir.
Very nice. Very
Thank you, sir.